Bismillah ar-Rahman ar-Rahim. The topic today about hip dysplasia, it is about building a rational approach to ultrasound assessment. The story of ultrasound and hip dysplasia is a long story with different schools in the world. Some European schools are advocating the use of angles. The American school are advocating more the dynamic study. So we'll try in this lecture to approximate between the different views and to build up a rational approach or practical approach which allow us in 5 to 10 minutes to fully evaluate the pediatric hip about the possibility of presence of DDH, why the controversies exist, why different schools exist, because the natural history of DDH, it is not a simple task. DDH is composed of two different elements, instability and abnormal morphology of the hip joint. The technique for performing an infant hip sonogram may vary depending upon one's belief as to pathophysiology. Initially, the focus was by Graf, who was an Austrian radiologist. He insisted on the acetabular morphology and therefore developed different static sonographic views and different angles for evaluation of the pediatric hip. That was Graf, the Austrian radiologist. Hark, he was American, on the other hand, emphasized assessment of instability of the joint in addition to the morphology and advocated a dynamic sonographic technique. In reality, both views can be performed in one setting if we really get use of every second of our examination or our time. The current recommendation actually requires assessment of both instability and morphology of the hip. Hark has developed these views. He stated that 4 views or 4 positions for the pediatric hip should be used: the coronal neutral, the coronal flexion, transverse flexion, and the transverse neutral, as we will see in the image. Some are useful mainly to study the acetabular morphology, and some are used for studying the stability of the joint. Here, a picture of the correct coronal view. You can see that the probe is put on the iliac wing in a very slightly posterior location, while if you move the probe 90 degrees, you can acquire a correct transverse view. The morphological assessment of the hip joint, it is based upon the appearance of acetabulum in a coronal neutral position, and afterwards describe measurement of the acetabular slope, which is the alpha angle, and the acetabular labrum, which is a beta angle. The benefits of the static image is that the DDH is known to change with time. It is greater at birth and decrease gradually in the first few months of life. So that means that the distinction between normal and abnormal in the first few weeks of life, it is important. Large number of newborns have mild instability that has been described as physiological laxity, and in addition there are cases of mild acetabular dysplasia. So in using graph angles, you have some figures, some angles that will allow you to categorize this patient early in life, either as mild instability or laxity, either mild acetabular dysplasia, or subluxable or dislocatable joints. The most important thing in evaluation of the morphology of the joint is to do a proper view, proper technique. The proper coronal view should follow these strict parameters. First, the echoes from the bony ilium should be a straight line parallel to the surface of transducer. If it is oblique like this or oblique like this, or curved like this, that means that the position of the transducer is wrong. So it should be straight and it should be parallel to the surface of the transducer. The transition between the os ileum to the triradiate cartridge should be seen. And then finally, the echogenic tip of the cartridge labrum should be present at the same plane as the ileum, the cartridge of the acetabular roof, and the triradiate cartridge. You can add to this the iceberg appearance appearing in the most posterior aspect of the image, which represent the pubic bone. Here again, the criteria of a good coronal view, which according to this, the different measurement will be made. So every effort by the sonographer or radiologist should be made to obtain this reproducible and this correct scan. The ileum, which is straight, parallel to the surface of the transducer, the acetabular floor with the area of junction with the triradiate cartridge, the echogenic acetabular roof with the echogenic labrum shown in the same plane, and lastly, in my opinion, this is very important, this like a mouse, angry mouse, this represents like iceberg, as you like. This is the pubic bone and should be present in the same plane as all this structure. The femoral head, acetabular floor. Some authors describe ball in a spoon. This like a spoon, and this is like a ping pong ball inside the curvature of the spoon. So again, this is the ileum, this is the acetabular floor, acetabular roof, echogenic labrum, triradiate cartilage, and the pubic bone. All these structures should be present as illustrated in this image, and then you will take the measurement. You take a horizontal line, extension of the iliac wing, and then two lines intersecting each other, one representing the acetabular floor and one representing the acetabular roof. This one is the alpha angle and this one the beta angle. So the correct appearance will allow you to correctly evaluate the morphology of the joint. So imagine here, this is a very bad technique. You can see here that the iliac bone, it is not straight, it is not parallel to the transducer, it is plunging, diving, and here you cannot see the triradiate cartilage, you don't see this mouse view of the pubic bone, you don't see anything. Of course, it can be erroneously diagnosed as dysplasia. This is not dysplasia. Here, when you adjust all the parameters, you can find that this is a completely normal joint. Graph classification of the infant hip is based on the depth and shape of the acetabulum. 4 types has been described. The normal, which is the ball in a spoon, as we said, the ball is ping pong ball, which is the cartilaginous femoral head, inside the spoon, which is the well-curved, the acetabular floor. So the normal, it is well-formed acetabular cup with the femoral head inside. Type 2, it is immature in infant less than 3 months or mildly dysplastic in infants older than 3 months. We will see what are the measurements he gave to them. Type 3 and type 4. Type 3, it is subluxated. Subluxated means it is away from the joint but still has a relation with the acetabular floor. Dislocated has no relation with the acetabular floor. Here, all the angles described by graph, we can remember from all these values only some measurement. Like the normal alpha angle, it should be more than 60 degrees. That will form a good cup of the spoon to lodge the ball inside. Type 2A, it is between 50 and 59. In this category, if it is after 3 months, it is considered as mild dysplasia. If before 3 months, it is considered as immature hip. In type 3 and 4, these all are decentered hip, either subluxated or dislocated hip. Type 3 sometimes are divided into A and B. Here an example of a dislocated hip joint. As you see here, the femoral head is completely away from the acetabular floor, and here the echogenic labrum is reversed. And there is a soft tissue between the femoral head and the acetabulum, because this created empty space will be occupied by the echogenic labrum. Type 4, it is more dislocated, with the alpha angle decreased, less than 60 degrees. It reached sometimes 40 degrees and less, and beta angle increased with the measurement approaching 77 degrees. Here, this is another notion of the morphology of the joint. It is described by the French literature as percentage of coverage, or equator sign. They said if you draw a line continuous from the iliac wing, it should intersect 50% or more of the femoral head. If it is less, that means that it is subluxated or dislocated. Here is the line which cuts the femoral head. Here is the full circumference. Here is the area covered by the iliac wing. As you see here, it should be more than 50%. The value of this, you can grade and you can easily recognize the state of the joint, whether subluxated or dislocated. Here is normal, but the iliac wing, you can see it is covering 50%. The degree of coverage here is less, maybe 30%. Here it is more and more less, maybe 25%. Here there is no coverage at all. So the equator line is also another adding point to the different graph angles. All this we have described the morphology of the joint by graph angle or equator side. The second step is the stability assessment. If we imagine you begin now to examine the patient, maybe in the first 5 minutes you have a full idea about the morphology of the joint by taking the adequate coronal and the transverse angle and taking the angle either in the ultrasound machine or afterwards in the PACS. I prefer to take standard views and then make the measurement afterwards in the PACS system. Stability assessment will depend on some maneuver which will be taken in the second phase of examination. The baby will be put in this way. The transducer is parallel to the iliac bone, slightly posterior, so that you obtain coronal scan, and the hip is flexed, flexion of the hip joint and knee joint. This is the optimal position. Of course, after the coronal, you can turn your transducer 90 degrees and take cross-sectional. The stability assessment, before making the maneuver, the patient must be relaxed. The patient should be cooperative. It is requested that sonogram be performed in a quiet and semi-dark room with the parent present inside. Also, bottle feeding will help to relax the infant while making the maneuver. You cannot imagine making a maneuver with baby forcing his legs. You cannot take anything from him. So relaxing the patient and finishing the examination as early as possible, from 7 to 10 minutes, it is crucial. Here, the different dynamic test while putting the probe in the coronal scan, Barlow test, which is corresponding to the Barlow maneuver in clinical examination. The hip is forcibly abducted, that means pushed to the inside, and you see the joint. Sometimes the femoral head comes away from the acetabular floor, and here it is subluxated or dislocated according to its coverage. Ortolani test or Ortolani maneuver, this is done after you diagnose a dislocated joint. From the first phase of study, when you are putting the coronal image, if the femoral head it is already dislocated, then you will make forced abduction. Here you will take the hip of the joint away, and you will see is it reducible or not. So ortholenny test is done only with the dislocated joint. Subluxation and lesser degree of instability can be reduced by ortholenny test, which is forced abduction. The key feature of instability is the lateral movement of the femoral head along the ischium with forced adduction or reduction of the femoral head by forced abduction. This is a dynamic testing. At rest, you can find this is typically normal examination and a very good scan. The iliac bone is straight, parallel to the transducer. These are the gluteus muscle, gluteus minimus, gluteus medius. This is the acetabular roof, the echogenic labrum, acetabular floor, triradiate cartilage, pubic bone, and femoral head inside. So with stress, adduction, you see what happened. Here, the femoral head, it is becoming subluxed. It is not dislocated, but it is subluxed. And you can be sure of the presence of subluxation by measuring the equator sign and the degree of femoral head coverage. So in summary, ultrasonic evaluation of DDH includes two-stage: the morphological assessment, which is depending mainly on the different graph angles, and the stability assessment by the different dynamic maneuvers, either by stress abduction, that is Barlow test, for testing the instability of the joint, or ortholenny dynamic study for the already subluxated or dislocated joint. Acquired data depend on proper technique. These are my reference, and thank you very much.
Thank you very much. Dr. Benesi, can you please just stay on the stage, please? Yeah. Now we would like to have our discussion. The hall is open for discussion.
Both Dr. Bahanesi and Dr. Shalan for excellent lectures. The question is to Dr. Shalan. Now, in sickle cell disease patients, the main vascular problems usually arise from either a vasculitic insult or small thrombi, rather than vessel narrowing or stenosis.
Yes.
So now, when you do your transcranial Doppler, actually the assessment of how reliable is the assessment of the infarction or areas of by assessing only the vascular or resistive indices.
Okay.
So in your practice, how much is this reliable? Because I think it will be a waste of time if you don't give us really, for example, enough data to say that this is quite a good thing, a screening program to assess susceptibility of patients of, say, but if there's no really convincing data, I'll just go in straight and do a MRI to see if there is any ischemic infarction.
Sure.
Just like what we do in imaging of the lungs in patients with sickle cell disease. So
Sure.
please, would you like your opinion on that?
Sure. I mean, the whole idea of TCDI, we want to prevent stroke. So the idea of waiting for the patient to have strokes and to have narrowing is something we would like to avoid it by TCDI. TCDI is a screening modality. You're measuring the hemodynamic of the intracranial vessels, and based on well-published data, okay, from the STOP trial 1 and 2, there are certain reference values that you can predict this child, let's say, for example, a child with a velocity of more than 200 centimeters per second, which has been confirmed twice in a 1-week interval. This child is a higher risk than the other kids to have stroke in the future. So this child will benefit significantly from having blood transfusion or hydroxyurea therapy from the hematology point of view. Talking about the strokes or the narrowing, this is kind of a late stage that we would love to avoid by TCDI. TCDI is useless when you have stroke. If you have stroke, I mean, you have it already, right? And the therapy of patient who's having stroke already is now you are preventing other strokes to this child, right? The TCDI idea, if you have a child, sickle cell disease, proven by genetics, should be screened from age of 2 years till 16 every year. And those kids will be monitored every year, and you can predict which patient will benefit from blood transfusion or not. Regarding your convincing data, I think the STOP trial 1 and 2 are very, very significant data, and they have significant impact on the clinical practice, and I think internationally it's used, so they are useful, not useless.
Any other questions? Dr. Materi, your mic is not on.
Now it's working, it should be all right. Now, in congenital hip dislocations, you're not really doing anything at all with plain radiology. You're not relying on any just initial clinical examination, then plain radiology, one shot, and see how, especially the acetabular dysplasias and hypoplasias and so on, regarding measurement of angles and this. In your practice, is it of any use where you're giving away completely with it and going to ultrasound directly?
I think now ultrasound is established as best screening method for DDH in the period from first month. Before first month, we don't do because presence of maternal sex hormones, up to ossification of the femoral head center, which is around 6 months. To diagnose DDH with plain X-ray after ossification of femoral head, I think it is too late and not justified in our community after the presence of all these ultrasound machines and expert doctors. So now we are making our main diagnosis by ultrasound. The late cases who come for different reasons from remote areas, we cannot do ultrasound, for instance, in 7, 8 months, 1 year. So we return back to the plain X-ray with known lines. I have to say also that there are some discussion about is it logic to do screening program for DDH. They refused this because of over-diagnosing dysplasia or laxity or mild dysplasia by ultrasound. So no screening program, but still with the graph method we have some angles to follow up, at least to be sure that the questionable issue of DDH is solved within the first 6 months before occurrence of serious complication. It is not accepted to now have false acetabulum and all this disfigurement. It will be too late.
Dr. Shalan, Assalamu alaikum. Thank you very much for your presentation. Kindly, I have just 2 simple questions. Number one, if you don't mind, there is an age, certain age to stop screening for a sickle cell disease patient or not? And from our experience in our hospital, we sometimes in a patient for ICU, he's not a sickler. We sometimes do practice of transcranial to the temporal for perfusion status, post-infarction. I don't know if we can still apply the same rule for, this patient who has infarction 60 or 70 years old. Sometimes we do transcranial Doppler to check the vascularity and how is the perfusion after a good hibernization like that.
Yes.
The same question, do we have a certain limit to stop screening, or we still going to screen this patient to avoid in the future, as you mentioned, the stroke possibility? Thank you very much.
This is a good question. I mean, the TCDI application is very wide and very wide spectrum, and it has been used in adult and pediatrics For example, in the adults, it has been used for CVAs, for subarachnoid hemorrhage, also for brain death determination with certain reference values and well-established data. From our side as pediatric, the main kind of purpose for TCDI is the kind of the screening for sickle cell, and I think the recommendation is to stop screening until age of 16. If the patient passed the 16 years of age with no incidence of stroke, their risk is very, very, very lower. I mean, there is a study about the risk of having stroke and sickle cell disease. It is much higher than in the less than 10 years of age compared with the teenager group. So recommendation is to stop the screening, but the application of TCDI are very wide spectrum. So you could use them in adult and pediatric and different varieties of clinical situations. I don't have the time to talk about everything about TCDI. I was focusing about sickle cell screening. But yes, they could be used for brain death, for vasospasm and subarachnoid hemorrhage, for vascular malformations and HIE in kids, for example, or hydrocephalus, intracranial pressure, knowing the RI or resistive indices. So the applications are really broad, but the most studied application was the TCDI screening for sickle cell.